and we'll get started. I'm going to, unless someone speaks up, I'm going to assume people can see my slides and it's on the
Yeah, it looks great. Thank you.
All right, so thank you once again. So today I'll be talking about children with serious chronic illness in the ICU, both our current state and what I think might be some of our future. My three objectives are for all of us to recognize the impact of children with serious chronic illness on ICUs and the impact of chronic illness on these children. Next, to characterize strategies that can mitigate the impact of critical illness on these children. And then finally, to appreciate that these patients are aging and will increasingly utilize pediatric and adult ICU services. So first, I should probably try to define the population I'm talking about. And it's really no easy task. For well over about 25 years now, people have come up with different classifications for the children with serious chronic illness. And you'll see some of them there. Some of the more common ones include the complex chronic condition, children with medical complexity. Increasingly, this term chronic critical illness is being used as a term which the pediatricians have stolen from the adult world, have given a kind of much more of a nebulous definition what's used in the adult world. And so one of the points I like to make is actually tremendous overlap in these classifications. And if it's not obvious already, having you glance through some of them, is that there's considerable heterogeneity in these groups, both in terms of their conditions and their severity, and both between the different conditions and within the same ones. A commonality is that their chronic conditions leave them susceptible to many health risks, including acute on chronic critical illness and high intensity perioperative needs. Because many of these patients begin their medical journeys in pediatric ICUs, many return, some frequently, and some end their journeys there too. And so while they live with severe chronic illness, many can only do so because of the care they receive in pediatric ICUs. So to first start addressing the impact on pediatric ICUs, and what I'd like to point out is they're highly prevalent in pediatric ICUs. So there's a retrospective cohort analysis of about 53,000 admissions to 54 US PICUs in 2008. And this showed that the prevalence of chronic conditions in those patients was about 53% for complex chronic conditions and about 18% for what we call non-complex chronic conditions, things like asthma, things like that. And there's actually quite a bit of a range between these 54 PICUs for those chronic conditions. About 5 years later, there was another multi-site study done and found this similar proportions. And in fact, there's some literature that shows that PICUs in low and middle income countries have similar proportions of patients with chronic conditions. So what this means is that PICUs actually have grown in part because of more children with serious chronic conditions are surviving. They're surviving longer, and they're surviving with greater complexity or more comorbidities. To give you a sense of this, between 2001 and 2016, in the US pediatric population grew about 2%, but PICU bed numbers grew about 43%. And most of this growth was actually seen in larger PICUs. The children with serious chronic illness is a big part of this, and so are children with congenital heart disease. If we turn to what their utilization is for this group, this is a retrospective cross-sectional study of about 136,000 patients admitted to 30 ICUs over about 3 years. And what you see here is in the bar graph, the darker lines, the darker portions represent children with complex chronic conditions. The mediums ones are the non-complex chronic, and no chronic disease, lighter shade. And you can see that disproportionately, this patient population speaking of uses up more and more resources, including the number of encounters, admissions, their costs, ICU days, and total ventilation. So at all categories, it's the children who are complex with these chronic conditions taking up beds and using more and more resources. not only are they prevalent, but they actually can have long stays. So again, the retrospective study of 53,000 patients in 2008, we found is that those with serious chronic illness were at greater risk for having prolonged ICU stays. So if they had one complex chronic condition, their adjusted odds ratio was about 2 for having a length of stay in the top 5th percentile. If they had 2 or more complex chronic conditions, their adjusted odds ratio went up to about 4.5. So there's also a small but notable group of patients who remain in our ICUs for weeks or months. And so this will give you a sense of those patients. So this data represents 2 studies, one out of Australia and one out of the UK, where they looked at their patients who stayed for 28 days or more. And they found that, these patients, while they represent a very small proportion of our patients, maybe 1 to 3%, they utilize between 18 and 32% of total patient bed days. So very disproportional. And then to give this context, probably median PICU stay is about 2 days, and a mean PICU stay is about 3 to 4 days. We also sense that this group of patients is growing. So these same 2 studies, they actually compared their numbers to previous decades. So they went from the Australian ICU, went from about patients who stayed more than 20 days having used up 8% of their total bed days to 21%, and the UK study going from 21% to about 43% of their total patient days. So a growing phenomenon. These patients also have readmissions. They come back. Sometimes they're referred to as frequent flyers. And so when we look at early unplanned readmissions, or admissions that happen within 48 hours after discharge from the ICU, we find that these patients, again, are at a higher risk. So this data is from a retrospective cohort analysis of 96,000 patients to 87 North American PICUs between 2009 and 2011. And so in that whole group, about 1.2% had an unplanned readmission to a PICU within 48 hours. Those readmissions, they actually had longer stays and higher mortality rates than their indexed admissions. And we found was doing adjusting for 2 different things amongst other covariates, their complex chronic conditions or their level of disability. And both showed basically the more chronic you are, the more disabled you are, the higher your odds of coming back and having an early unplanned readmission. Well, that was just early unplanned readmissions. What about readmissions on a longer time scale? So we subsequently looked at a sample size of about 93,000 patients amidst 76 PICUs, and found that if you have complex chronic conditions, and the more you have, the more likely you are to return to an ICU for an unplanned readmission within a year. So 11% of patients, all patients, had an unplanned readmission within a year. 2% of the patients had 2 readmissions, and about 1.5% had 3 or more readmissions. If you had a complex chronic condition, the 21% of those had an unplanned readmission within a year. And if you had 3 or more complex chronic conditions, about 1/3 of those patients would return in a year. These unplanned readmissions also accounted for 20% of all patient care days. So yes, we do have patients in our ICUs that we get to know because we see them again and again. So that's the impact on the ICUs. And while their impact is certainly considerable, the actual burden of critical illness on these children is what I would call profound, given that they have such high risk for mortality and morbidity. So again, in a retrospective cohort analysis of 53,000 admissions to 54 PICUs, we found that there's a greater risk for PICU mortality depending on the number of complex chronic conditions you have. So the more complex chronic conditions you have, the greatest your odds of dying while you're in the ICU. And just the overall PICU mortality rate was twice as high for children with chronic conditions versus those with no chronic conditions. Other studies have looked at their greater risk for mortality a year after PICU discharge. So not just PICU mortality, but just their all-cause mortality. And then besides just mortality, these patients actually have a risk for being leaving the ICU after their critical illness with worse functional outcomes. So about 5 to 6% are discharged with having worse functionality scores. And this is a bit higher than patients who come in with normal functionality. So it's not just their morbidity and mortality, it's also they have higher medical errors, adverse rates, drug-drug interactions, and so on. So there was a study of about 4,000 records in pediatric inpatients, and they found that those with chronic conditions had 34 adverse events per 1,000 days compared to 14 adverse events per 1,000 patient days for the normal patients. Also, their adverse events were actually more severe, and their incidence rate of higher severity adverse events was higher than compared to normal patients. 6% of these patients had some sort of medication error. And then they're also a greater risk for drug-drug interactions. So patients who have more than three complex chronic conditions had a 5 times greater risk for having a drug-drug interactions. And also, while many of these children have prior PICU admissions or have neurodevelopmental delays, it should not be assumed that they're any less susceptible to intra or post-ICU emotional stress, as there's actually no evidence of that being the case. There's also the impact on the family themselves. So just as the children are at risk for physical and psychological morbidity, so are their families at risk for psychosocial morbidity, as having a patient or child in the ICU can cause high levels of stress, loss of income, both during and after admission. And there's no evidence this is less true when a child has been previously chronically or critically ill. So especially with their families who stay there for weeks or months, they're especially susceptible to loss of income and social isolation. And it should be important to note that there's the impact on families is probably greater for racially or ethnic minority patients and families, or non-English speaking patients and families. As we know from evidence, they actually have more unmet informational needs, less engagement in communication and shared decision-making, more decisional conflict in white families. Disparities at the end of life can also be found for these groups. And of course, there's the language and cultural barriers, which have been linked to risk factors for post-PICU psychosocial adverse outcomes. It's also important to mention not just the impact on the children, the impact on their families, but impact on providers. So the challenges of caring for some of these patients is often linked to staff moral distress and burnout. Moral distress being the angst we experience when we're unable to care for a patient as we think we should be able to. And so commonly, those feelings of moral distress are wrapped around perceptions of futility or questions of quality of life for our patients. But there's also good evidence that moral distress is linked to a lack of continuity and poor communication, leading to perceived poor care. And it's also, it's these patients, the ones with serious chronic illness, which are the focus of most of our ethics consults in our pediatric ICUs. So we should talk about the pediatric mindset. And because I think it's important to highlight that our mindset and how it's the way we deliver care is actually probably contributing to some of the impact of negative impact of critical illness on the patients and families, and perhaps on the providers as well. And so we're all intensivists. We pretty much know that we are pretty much acute care focused. And while critical care's focus on acute illness serves patients well when they don't have chronic illness or have relatively short lengths of stay, it kind of manifests as transitory or even fragmented fragmented care for other patients. So, intensivists change every week in my institutions. There's some places that change every 2 weeks. I know some places that change more frequently than that. Nurses work in shifts. And so this transitory or fragmented care can insufficiently meet the needs of children with severe chronic illness, especially those whose illness can outlast multiple providers. And so because of this, what we have is, what I consider a kind of framework for what happens in these situations. So the resulting fragmented care from our change in providers and our narrow focus on acute care can result in things like ineffective information sharing and retention. We can all have varying goals, approaches, timelines, and patient familiarity, and that can change each time a new provider comes on. We can have inattention to the big picture chronic issues. And then this all can lead to things like adverse events, delayed decision-making. We just kick things down the road to the next person. And then ultimately family frustration and impaired confidence, trust, and rapport. So what happens is we get caught in a situation where we feel like we're not doing right by our patients and their families. And some places have taken it upon themselves to come up with strategies to augment our usual care of rotating providers and try to make things better and mitigate some of the impact of critical illness on these patients. And so I think it's first and foremost, these strategies, or the best strategy, is those using patient and family-centered ICU practices, which are fairly well established, which I won't really go into. But I want to talk about more other practices that are used sometimes to augment usual care. And so these strategies can be, I think, grouped in 4 different categories. Those are centered on continuity, those that center on palliative care and complex care, family and patient involvement, and then training and continuing education. And a unifying theme to all these strategies is that the on-service team alone cannot ultimately care for children with severe chronic illness, especially when our patients stay for weeks or months. So dealing first with continuity. So this comes in different flavors. So there are things like PICU navigators. And so a navigator is a trained person who provides emotional communication, decision-making information, and transitional support through having regular meetings with the patient and family, and then post-PICU check-ins. There's also primary, or what's sometimes called continuity intensivists. And so this is when one intensivist serves as a consistent physician resource, facilitator for a long stay or repeatedly admitted patient and the PICU team. So, and they do this despite the service intensivist who still orchestrates all management. But their duties include things like attending all family and team meetings, regularly checking in with the family and the team, being a resource for them in whatever way they can to facilitate things like decision-making and the like. There's sometimes this type of continuity comes in the form of a team, so it's called a chronic care team. There's also primary nurses. And so this is when a small team of PICU nurses provide most of the patient's bedside care, but they also take an active role in family meetings and in shared decision-making. So going above and beyond what a normal ICU nurse would already do. And then some places will have multidisciplinary team meetings. And so this is different than, our IDR, daily IDR. And this is where they meet every week or every other week. And they'll discuss complex or long stay patients to address their medical, ethical, and psychological complexities. And they basically, in order to get all the intensivists, they're all invited, and any and all other staff at the table to ensure consensus in care plans, a collective awareness of the patient's history and issues, and a supportive community. And there's actually some evidence that these multidisciplinary meetings can decrease nurses' moral distress, which I think is pretty phenomenal. Going to palliative care and complex care. So ICU palliative care, as you all know, seeks to relieve distressing symptoms, improving communication, especially around goals of care, decision-making, and also providing, and I think what they're doing more and more in our ICUs is giving caregiver and staff support. And so what I mean by this is I think it includes both secondary or what's called subspecialty palliative care and also primary palliative care. And this is where all providers should be well versed in and practice on the core competencies of primary care. The important thing is that palliative care is initiated early in the courses of these children, for which most of them, almost all of them, would qualify for, benefit from. But there's evidence that not all who would benefit actually receive it. And there's actually evidence of variation in who gets it across different chronic conditions, with things like static conditions, things like patients with static encephalopathy receiving less palliative care than patients with progressive conditions. There's also complex care. So this is sometimes large institutions will have complex care services who will do mostly outpatient, but also sometimes inpatient care of children with serious chronic illness, things like care coordination and the like. And so it's a good idea to bring these knowledgeable, outpatient providers into the ICU because their longitudinal knowledge and relationships can be utilized to add perspective to during the critical illness and support the families as well. There's actually some evidence that this actually works. There was a single-centered randomized controlled trial of inpatient consultation by a complex care service for their own children with medical complexity, and they found that the patients that received the consultation had fewer PICU days and fewer mean total health care costs. It's also important to improve patient and family involvement. This includes enhancing a partnership with our families and patients. And so most of the families want to be personally involved in the bedside care of their child in the PICU and involved with even minor medical decisions. Yet their participation input is often undervalued. There's evidence of that. And even though this is the case, they're actually the quote unquote experts in their child, both in their underlying condition and in their child's idiosyncrasies. And though while children and young adults with serious chronic conditions commonly have neurodevelopmental or other disabilities, many are capable to varying degrees to express their needs, their preferences, to assent to decisions, and to participate in their own care. And so allowing such involvement of these patients, really does, it improves humanization of them, because a lot of times in the ICU, we see them when they're the sickest, when they're not, what their parents see and experience them at. And we really do just a disservice to only kind of see them in this state when they're in the ICU. There's also things like ICU diaries. And there's some evidence that these ICU diaries can lower anxiety and depression in patients. They are used for pediatric patients. And so basically, you may already know, these diaries are basically non-technical personal reflections, encouraging messages or images or other entries by, it could be the patient, the family, or provider, and they're meant to mitigate the psycho-emotional negative outcomes. And, there's only been about a very small handful of this use in PICUs, and just showing that parents accept them and, kind of view them as beneficial, but no more evidence than that. Before going on, I want to talk about just the last one, that is the training and communication and continuing education, excuse me. And so basically, pediatric training programs in major hospitals and residencies have come to realization that these children are different from others, and they require their own set of skills to care for them. So what they have done is they've gone ahead and created kind of curriculums for these patients. And while I've not done so yet, I do believe that some of these complex care curriculums could be adapted and should be adapted for PICU providers. So we just went through a whole bunch of strategies, but I think it's important to note that there's actually limited outcome data for most of these strategies. And there's actually little consensus on what outcomes should be measured. So there really is a need for greater certainty of their benefits and their shortcomings. And that's needed to bolster both widespread institutional adoption and individual buy-in. And I'll give you an example. One of the things that is currently taking up a lot of my time as we're trying to start a multi-center randomized trial of these strategies, and that is primary intensivists and primary nurses. So again, this is when one intensivist will be a resource for both the family and the ICU team throughout the long stay patient's course, and then a small group of nurses will provide most of the bedside care. So they really are meant to provide both all three of informational, management, and relational continuity. And there's some evidence that these things do help. So these primaries, so that they improve team and family relationships, that for the patients that die, the patients that receive them have less intensive interventions at the end of their life. They improve decision-making, fewer adverse events, improve communication, improve family satisfaction. RNs who practice primary nursing report more empowerment and greater job satisfaction. However, we should note that this data really does come from a very small number of studies, mostly single-centered and mostly uncontrolled observational studies. And what this handful of studies do show is that these primary practices can be time-consuming. They can be emotionally stressful, especially for the nurses. They can hinder nurse staffing flexibility, and they can also hinder nurse professional development. So, if you're an ICU nurse and you're taking care of the same patient for 2 or 3 months straight, that can contribute to burnout, and that is often not why an ICU nurse went into her profession, his profession, and it arguably decreases their professional growth. Even for the outcome that's been studied the most, which is length of stay, there's kind of inconclusive evidence. So for our own small single center study, we looked at primary nurses and primary attendings, and we found for 200 patients, we found a non-significant lower mean length of stay if they received primaries. And the same thing was kind of found for a randomized control trial of primary intensivists alone. They also found a non-significant lower length of stay. On the other hand, retrospective multi-centered study does show that having primary in units that use primary intensivists and primary nurses have about a 10% lower mean length of stay relative to places that don't use primaries. So again, the effectiveness of these strategies is still out. Even from my understanding of the adult literature, things have not always been shown to be effective when trying to address patients with chronic critical illness. So for example, a study of palliative care-led family meetings for these patients showed no significant difference in family anxiety and depression at 3 months. A large study of ICU diaries in 35 French ICUs showed no significant difference in patient post-traumatic stress symptoms at 3 months or in any of their secondary outcomes. So I think the message for our strategies is there's actually no easy solution, and it doesn't mean we shouldn't continue to do some of these practices because we think they're just good care, but it does behoove us to continue to think of new ways to address the needs of these patients and to study them at the same time. So now to transition into what I think the future is for these patients in the ICU. And I think what that is that their numbers, children with serious chronic illness will continue to grow, as will their complexity. And the future of pediatric critical care medicine will continue to be intertwined with this patient population. And not just that, I think the future holds that these patients are going to age. There's now evidence that most children with childhood onset chronic conditions are expected to survive until adulthood. You know, many of these children will continue to use PICUs for their acute and preoperative needs in the near future. But what this table hopes to show is they're going to age to years past what pediatric ICUs are used to taking care of. So, you know, children or a adult with serious cerebral palsy, you know, is expected to have a median life expectancy of 17 years. Children with severe congenital heart disease, over 50% will survive until 18 years. Those with single ventricle and Fontan palliation, evidence shows that 70% of them will have a 25-year freedom from death and transplantation. Duchenne muscular dystrophy are surviving into their 20s if they're on long-term ventilation. And the mean life expectancy for a person with trisomy 21 is now 60 years old. And this actually might be a little old data because I collected this in 2015, 2016 for a chapter. So what does this mean? It means that we are right now seeing more and more adults in our pediatric facilities. So this table is from a retrospective cross-sectional study of 30 children's hospitals. And so, you know, it showed that compared to children, adults discharged from these children's hospitals are more likely to have a complex chronic condition. They have higher median costs, and they have longer lengths of stay. Adult discharges range from 2 to 10%, with a median of 4% from these 30 hospitals. And the proportions of patients with at least one complex chronic condition was higher in patients in the adult groups than in the pediatric groups. And so as you see here, over from 2004 to 2019, the percent growth of discharges is just increasing, and it's increasing more for older patient groups. So this growth is significantly higher in each of the adult age subgroups compared to the pediatric age group. So if we look at adults in pediatric ICUs, we already know that they're there. So in a retrospective cross-sectional study of about 68,000 patients, age 15 or more, to 70 PICUs, and this is old data, you know, about, what would that be, almost 3% were age 19 years or older. And this varied by hospital. So the proportion of adults varied between about 0 and 9%. And the study also found that increasing age was independently associated with greater odds of PICU mortality. This is even with adjusting for severity illness scores and number of complex chronic conditions. So why are adults, you know, in their 20s and even in the 30s still using pediatric ICUs? And I think it's a number of reasons. One is that the pediatric hospitals have, you know, specific knowledge about their childhood onset chronic condition. Also, patients and families have pre-existing relationships with their pediatric providers, which they do not want to give up. Pediatric hospitals provide developmentally appropriate resources for these patients that often are developmentally delayed. And we have certain accommodations which the parents get used to. And they don't want to give up. There's also just a lack of planning, both from the patients, the families, and the providers. And then finally, I would suggest there's actually financial incentives for hospitals to keep these patients, especially for those who are involved in kind of procedural or surgical programs. But for the foreseeable future, adults with serious childhood onset chronic conditions will continue to receive care in children's hospitals and pediatric ICUs. But as they age, these adults will ultimately become susceptible to diseases of advanced age. So this, plus their growing numbers, I believe will result in increasing demand for and impact on adult critical care and other inpatient services. And for adult ICUs, I think this will mean additional strain on your resources, new challenges for caring for potentially unfamiliar conditions and populations. More and more adults with congenital heart disease and other congenital conditions, adults with neurodevelopmental disabilities who have unresolved guardianship. And I think that is what the future will hold for both of us. And while I say that, I'm not trying to argue that this is some sort of tsunami that's coming. I think it'll be more of a swell of patients that we will increasingly see impact our ICUs. And so we should talk about, who goes where for these adult patients, and does it matter? And there's actually some evidence, a little bit of evidence right now for what the current state has been. So this is from a retrospective cross-sectional analysis about 6,100 adults aged 19 to 40 years old, admitted in 2008 to 68 PICUs and 50 adult ICUs, and trying to compare the two populations. And what we found here is that adults with childhood onset chronic conditions were admitted to PICUs were significantly more likely to be younger, to have a worse functional status, and to be non-trauma compared to adult units. So we think, the evidence that we have so far is that adults going to pediatric versus adult ICUs are just kind of different populations. What about their outcomes? So if we just look at the adults, and there's no sort of proportional matching or anything like matching with this, but the length of stay is very similar, and as is the ICU mortality between these two groups of adult patients. What about if we grow down to kind of a more specific, subset of patients? So this is a different study, a retrospective study of adults aged 18 to 21 years with severe sepsis in a multi-state employer-based insurance and Medicaid databases from 2010 to 2015. And what they did is they looked at these patients, and they had 163 adults that were admitted to pediatric ICUs and about 1,000 admitted to adult ICUs. Again, there was a bit of an age difference with the younger patients going to pediatric ICUs. And they also looked at comorbidities, and they did this identifying using the pediatric classification, the complex chronic conditions, and adult classification, or the Carlson Comorbidity Index. And they found that basically there's this kind of the same median number of complex chronic conditions for patients, but they did know that PICU patients were more likely to have genetic, hematologic, immunologic malignancy, neuromuscular, or transplant comorbidities. The Carlson Comorbidity Index was a little bit different, and the amount of patients on Medicaid was quite different. As far as outcomes, so remember, these are patients who all had severe sepsis. So the main outcomes for this study was in hospital mortality and hospital length of stay. And in this, they showed there was really no difference in hospital length of stay. And the cost was different. It's cheaper to be admitted to adult ICU for severe sepsis. And the hospital mortality, one might argue, goes to a benefit of being in an adult ICU, where those admitted to the children's hospital, if you consider the comorbidities being the same, have a higher hospital mortality than if you were admitted to adult ICU, or a 50% lower adjusted odds of mortality. The study did note some important differences in specific comorbidities that are unaccounted for, and a possibility of differences at the level of the treatment location, which they couldn't account for. So I think some of the questions we have to ask ourselves is for the future is, do PICUs have the expertise and resources to care for adults with childhood onset chronic conditions as they age and as they develop age-related diseases? And then do adult ICUs have the expertise and resources required to care for the more complex adult with these childhood onset chronic conditions? And not just that, they also have to care for their families, who are very much accustomed to a very different healthcare culture, one that involves much more liberal visitation, informational access, and decision-making deadlines, and also a greater participation in their loved one's bedside care. So to address this, I think our future needs to have, one where we, both pediatric and adult intensivists, collaborate. And we should be eventually collaborating things like how we care for these patients, the triaging of where they go, transitioning. So, getting them eventually, if they keep using a pediatric ICU, eventually moving them to adult providers and then adult ICU care, training of each other's trainees, and then also research. So with that, some concluding thoughts, and then I know there's some things in the chat that I look forward to looking at. I haven't had a chance to do that. My first thought is just the children with serious chronic illness are already the most prevalent pediatric population in PICUs. This vulnerable population will undoubtedly grow and become more complex and age. The strategies beyond acute care focused transitory care are needed to address their distinctive needs. And then finally, the future of pediatric and adult critical care medicine involves caring for adults with serious childhood onset chronic conditions. And so with that, I want to thank the patients, families, and my colleagues, as well as my funding sources. And I look forward to questions or comments or conversation. And thank you.
Thank you so much. That was really great. Sorry for my voice, Dr. Edwards. I had one question for you.
Yeah.
So I had a patient in the ED that came in who was 24, CP, kind of chronic critically ill, as you talked about. A lot of her providers were in the pediatric side of the hospital, but recently she had been transitioned. The peds hospital and the PICU no longer was admitting them. They were kind of getting pushed into the adult side, and the family was very frustrated and very angry about it. And so how do you guys deal with those kind of situations? Is there a formal kind of way you transition them?
I too am in a hospital where, we're under one umbrella. This is one hospital system. And, there is right now, no collaboration. There's loose guide suggestions about ages of patients and where they go. But beyond that, I feel it too, where, when they're critically ill and need an ICU bed, that's probably not the time to be figuring it out. It's now, forcing a transition. But it does kind of, to me, scream the need to something that needs to be addressed after the critical illness is over. I also remember distinctly, we had a patient who was 19 years old, pregnant, and with severe influenza pneumonia, very sick. And we found out that the adult ICU had the kind of patient you described. So a patient with profound cerebral palsy and static encephalopathy, who was 20 some years old, but weighed 30 kilos. And we gladly traded something. They were much more familiar taking care of a pregnant patient. And we took that patient back in their patient in a heartbeat. So I too have been a part of these things as well.
Yeah, it just seemed like this had already started, and the patient had already been and started to be admitted to the adult side, and just the family just wasn't accepting it. And so it just made it really.
It makes it challenging. The the families can be resistant to going over just things are different.
Yeah.
You know, I don't think worse, but just different. It's not what they're used to. And maybe we babied them for too many years, that they like the way things are on the pediatric side.
You guys are a lot nicer than we are sometimes.
Well, it's still the number of conversations, it's very obvious, and I've had to use this with families about, for example, tracheotomy, initiation of long-term ventilation. So we will, you know, in the pediatric world, we will leave patients, you know, intubated with endotracheal tube for months before we finally declare them as, oh, this patient has to have a trach or allow natural death. And from what I understand, that's just very different in the adult world.
Yeah, we usually try to trach by day 12.
For us, that would be very much a rarity, but it does happen, but a rarity.
I'm happy to open up to anyone else that has any questions for Dr. Edwards. Okay. Well, if there are no other questions, I will give everyone back 10 minutes of their day. Thank you again so much. That was a really great lecture. I really appreciate it.
Thank you so much. It was a pleasure. Take care, everyone.
Bye.